that's the beauty of retinal medicine is it's a different song and dance with every patient. So I had some patients that are obviously pretty frustrated with chronic therapy, and they're really willing to give it the 4 loading doses to really assess for any benefit. And I've had other patients that after one and it's not really looking any different. You know, all of our patients are already coached on looking at their OCT scans and comparing their visions even before we come in the room. They're not really assessing much of a response. I've had some patients already just want to switch back to whatever they were receiving before. So that again is kind of the beauty of retina medicine and the disconnect between what we see in clinical trials versus the real world that I'm sure you'd all agree with. One comment, I mean, when you go back and look at the clinical trial data, so for AMD was specifically with TENAYA and LUCERNE, does the panel have any comments on, you know, are we definitively seeing increased durability here? Like, I was personally a little disappointed to see like no added efficacy in terms of visual acuity gain. Nothing's been to date, nothing we've tested has been able to show, you know, superior visual outcomes. But what do the panel think about durability? Are we seeing a true increased durability effect here when you look at the data?
You know, I think the problem in that essentially, Ehsan, is that, you know, it's a non-comparative study in many ways, right? So you're not really comparing aflibercept to faricimab in a head-to-head fashion. It's more for aflibercept given in its best possible, its labeled dose, which is every 8 weeks thereafter, after the loading period. And so I think you lack that insight as far as whether it's truly a class differential with the drug. But I can say that the percentages that are being reported in the study are by far the highest percentages we've seen with Q16 and Q12. I mean, with 78 or 79% of patients achieving that, it's the longest that any trial has ever been able to show that. And the equivalent studies, if you had to do some cross-trial comparisons, you can see some data from other studies which looks similar, but it's definitely percentage-wise still lower than what we're at right now. So I guess I would say that it's not a perfect study in many ways, but at least it's the best we have, and it does appear to be having a significant amount of durability. I think the bigger one for me in actually in the TENAYA and LUCERNE studies are how many patients were on the Q8 all the way through, which is very, very low and continues to be maintained low over the course of the 2 years. And so I think that that's probably the more important thing to see, is that Q8 being so well controlled.
I think it will also be very important when the 2-year wet AMD study readout occurs this summer, because the first year we saw that, as you mentioned, 22% were on Q8 week faricimab, a third were on Q12 week faricimab, and 45% were on Q16 week faricimab based on this study design. And those numbers certainly were impressive, especially because the faricimab treated subjects met the non-inferiority visual acuity outcomes compared to aflibercept. But we'll have to see in year 2 if this extended durability that was shown with faricimab, does it still maintain the visual acuity outcomes, or will it cause any detrimental visual loss in the second year? Because in many studies, that's when the vision loss occurs, and we certainly want to avoid that.
Yeah, that's a great point, Diana. And along those lines, I think data a lot of colleagues have been inquiring about is to see how each of these swim lanes, if you will, performed acuity-wise. So it kind of all got lumped in together, but we know, you know, once you committed to a swim lane, be it every 8-week, 12-week, or 16-week, they stayed on that treatment interval for the duration of the study. So I know that we'll probably be getting how each individual group performed visual acuity-wise. That data is forthcoming, I think, is being analyzed as well too. And another comment I thought was always an interesting one, I'm curious what the panelists' thoughts are of this, is how little vision, if any, is gained from both arms. It's not a comment about faricimab or aflibercept, but in general, both groups gained about 6 letters of vision through year 1. And how do you all reconcile that? Is this, my impression was this is likely some degree of ceiling effect, and it, you know, it's kind of a tip of the cap to all of our eye care colleagues, be it optometrists or ophthalmologists, for learning to identify patients earlier on, getting them referred in immediately, and getting treatment on board as soon as possible. What do you all take home from that?
I took home very similar points. If you look at the visual acuity criteria, we enroll patients now in clinical studies with better visual acuity compared to the original studies for neovascular AMD. And we've really increased awareness that there is a treatment possible, so patients get to us sooner, and we can, save vision better. But the interesting thing is it showed in, across the treatment arms that the similar number of letters improvement.
Ali, for you, from the results we are seeing, can we conclude that this is all because of Ang2 inhibition and Tie2 activation, or is this durability we're allegedly seeing due to the increased molar equivalence of faricimab compared to ranibizumab?
Yeah, it's hard to say. I think again, depends on which outcome you're looking at. It's hard to make that decision. If it's just visual acuity, they seem relatively equivalent. But I think Rishi mentioned some earlier, OCT and anatomy drying effect of this drug versus the comparator arms. Possibly that's an explanation for where the Tie2 activation, comes in. How to exactly, decide what is coming from, the VEGF blockade versus the Tie2. It's hard for me to really see from the data. But I think the good news is, particularly actually in the DME data, or rather than the AMD, that the drying effect is a bit more with this dual inhibition. So I think, I'd be interested in looking at kind of the longer term outcomes to see if that bears out and what that might mean for the Tie2 pathway.
Do any of you worry about potential increased systemic safety events or risk of ocular inflammation, as it seems we're continuing to ratchet up the amount of anti-VEGF we're putting in the eye? Is there a balance here? I mean, we heard Bayview mention earlier. So far, the clinical trial data has looked somewhat reassuring from what we saw with TENAYA and LUCERNE and some other agents coming up. But do any of you worry about this increased potential for risk?
I think everybody has a heightened awareness because of the safety profile of brolucizumab, and clinical trialists are scrutinizing adverse events. Thankfully, the faricimab data appears very well tolerated, and we haven't seen those cases of retinal vasculitis or occlusive retinal vasculitis seen with brolucizumab. I think one of the agents you mentioned earlier, the port delivery system, which is a different mechanism because it's a reservoir that allows for every 6-month dosing, that does have a 3 times higher risk of endophthalmitis, severe infection, because of this indwelling device. And I think that is the biggest risk with the port delivery system.